record.
Okay.
That.
Hello. Hello.
Yes, bro. Start. You can start.
Okay. So, approach to thrombocytopenia. Sorry. Hello. Hi everyone. Welcome to our first Hansen-based webinar class. Approach to thrombocytopenia. So, just an introduction about the platelet. It's audible now.
Yeah. You can hear. Continue.
Yeah, it's audible. You can continue.
Okay, platelets are released from the megakaryocyte site, likely under the influence of flow in the capillary sinus. The normal blood platelet count is between 1.5 lakh to 4.5 lakh per microliter. The major regulator of platelet production is the thrombopoietin hormone, which is usually synthesized in the liver and other organs.
Firdause, bro.
Hello.
Can you make it a bit more clear? Mike, can you make it near your mouth?
Okay.
More. Yeah.
Okay. Is it clear now, Daniel?
Yeah, better, I think.
Better. Clear, like?
Yeah, clear.
Okay. So, continue. Synthesis is increased with the inflammation and specifically by interleukin 6. The thrombopoietin hormone binds to its receptor on platelets and megakaryocytes, by which it is removed from the circulation. Thus, a reduction in platelet and megakaryocyte mass increases the level of TPO, which then stimulates platelet production. The platelet, the average lifespan of platelet in circulation is between 7 to 10 days. Approximately 1/3 of the platelets reside in the spleen, and this number increases in proportion to splenic size. Although the platelet count rarely decreases to less than 40,000 per microliter as the spleen enlarges. Platelets are physiologically very active, but are anucleate and thus have limited capacity to synthesize more proteins. Okay, shall we move on to the next slide? Thrombocytopenia. So thrombocytopenia is platelet count less than 1.5 lakh. It usually results from one or more of the following three processes. Either it is due to decreased bone marrow production, or it can be due to sequestration, usually in the enlarged spleen, and finally due to increased platelet destruction. So before going into causes of thrombocytopenia, we have to first rule out pseudothrombocytopenia, particularly in a patient without an apparent cause for the thrombocytopenia. Okay. So pseudothrombocytopenia is an in vitro artifact resulting from platelet agglutination via antibodies, usually IgG antibody, but it can also be due to IgGM and IgG antibodies. When the calcium content is decreased by blood fraction in EDTA body. That is the purpose of body, to calculate samples and all, so CBCs. So if a low platelet count is obtained in EDTA bottle, a blood smear should be evaluated and a platelet count should be determined in a blood collected in a sodium citrate, that is usually blue cup tube or a heparin tube, that is pink cup tube, or a smear of freshly obtained unanticoagulated blood, such as from a finger, can be examined. Okay. So, in a nutshell, classification of thrombocytopenia, it can be either due to decreased platelet production, usually marrow failure symptoms, whether it can be due to congenital or acquired causes. Acquired causes usually aplastic anemia, then paroxysmal nocturnal hemoglobinuria, then can be due to hematological malignancies. It includes either marrow infiltration like cancer, granuloma, then myelofibrosis, then vitamin B12 or folate deficiencies. Then can be due to physical damage to the bone marrow, as in radiation, or due to alcohol, or due to chemotherapy. Then increased platelet clearance. It can be due to immune-mediated mechanisms, as in immune thrombocytopenic purpura, TTPs, then hemolytic uremic syndrome, post-transfusion purpura, then HIT, that is heparin-induced thrombocytopenia, and non-immune mediated mechanisms of increased platelet clearance includes DIC, then aortic aneurysm, acute hemorrhage. Then coming to infections associated with thrombocytopenia, HIV, HCV, HHV, then cytomegalovirus, Helicobacter pylori, E. coli, rickettsy and all, malaria. Then coming to increases splenic sequestration, as in portal hypertension, Felty syndrome, then lysosomal storage disorders, and infiltrative hematological malignancies, or extramedullary hematopoiesis. Okay. The history and physical examination, results of the lab value, that is CBCs, and review of the peripheral blood smear are all critical components in the initial evaluation of thrombocytopenic patients. That is, they have to send CBC, then peripheral blood smear. Then, except in unusual inherited disorders, decreased platelet production usually results from the bone marrow disorders that also affect RBCs or WBC production. Then, myelodysplasia can present with the isolated thrombocytopenia. So, the bone marrow should be examined in patients presenting with the isolated thrombocytopenia without any other parameters, and in patients who are older than 60 years of age and who do not respond to insulin therapy. And while inherited thrombocytopenias are rare, any prior platelet counts should be retrieved, and a family history regarding thrombocytopenia should be obtained. A careful history of drug injection should be obtained, if any, including non-prescription, then herbal remedies, herbal drugs, because drugs are the most common causes of thrombocytopenia we see in clinical practice. And coming to physical examination, there can be an associated enlarged spleen, evidence of chronic liver disease, and other underlying disorders. Mild to moderate splenomegaly may be difficult to appreciate in many individuals, as we see, due to body habitus or obesity, but can be easily assessed by ultrasound abdomen. So, any patients coming with a thrombocytopenia, we can send for ultrasound abdomen. A platelet count of approximately 5,000 to 10,000 is required to maintain vascular integrity in the representation. Okay. So when the platelet count is markedly decreased, petake first appear in the areas of increased venous pressure, like the ankles and feet, in an ambulatory patient. Then wet purpura, blood blisters that form on the oral mucosa are thought to denote an increased risk of life-threatening hemorrhage in the thrombocytopenic patient. So, in thrombocytopenic patients, you can look for wet purpura, usually in the oral mucosa. Excessive bruising is seen in disorders of both the platelet number and function. Now, the algorithm for evaluating the thrombocytopenic patient, as given in Harrison. So, in thrombocytopenia, we have to send CBCs, including hemoglobin and the white WBC count. If it is abnormal, then we can go for a bone marrow examination. If it is normal, then we can send peripheral blood smear. In peripheral blood smear, if the RBCs are of a normal morphology and the platelets are normal or increasing size, we can consider drug-induced thrombocytopenia. So, drug-induced thrombocytopenia can be considered normal RBC morphology and with the platelets normal or increasing size. And this is usually denoted by mean platelet volume, as we see in our CBC count. Usually, I think it is normal value is still 11. Then we can also consider infection-induced thrombocytopenia. idiopathic thrombocytopenia, and congenital thrombocytopenia. That if in peripheral blood smear, if we get fragmented RBCs, then we can consider microangiopathic hemolytic anemias like DIC, TTP, and all. And if the platelets are clumped in peripheral blood smear, we have to get another sample in sodium citrate or heparin, as we said earlier. So this is the algorithm for evaluating thrombocytopenia. Okay, so we'll go to specific investigations in different scenarios. In ITP, so ITP is immune thrombocytopenic purpura. We can send a peripheral blood smear to confirm automated platelet count, and we can assess for platelet clumping and to determine platelet RBC and WBC morphologies. Actually, lab tests do not confirm the diagnosis of primary ATP, although they help to exclude secondary causes. So, primary ITP often has the scenario of isolated thrombocytopenia in the absence of a likely underlying causative disease or medication. We can send for associated infective causes like HIV, HCV, and all. Then serological tests for antiplatelet antibodies generally do not help diagnosing ATP because of poor sensitivity and a low negative predictive value. The diagnosis of ITP does not typically require bone marrow examination, although it can help to exclude other causes in selective patients with additional CBC abnormalities unresponsive to immunosuppression therapy or atypical signs or symptoms. Then coming to TTP and hemolytic release syndrome, both TTP and HCUs they come under thrombotic microangiopathies caused by either platelet then 1 milligram factor aggregates and platelet fibrin aggregates respectively, resulting in the thrombocytopenia, organ ischemia, and microangiopathic hemolytic anemia. Usually, clinical and lab features permit differentiation of TTP from hemolytic release syndrome. And they occur in association with the DIC, HIV infection, malignant hypertension, vasculitis, and then adverse drug reactions, pregnancy-related complications like preeclampsia, eclampsia, and HELLP syndrome. We can see for the complete petad of TTP, which can help in diagnosis. Actually, it is usually present in less than 30% of cases, including conceptive thrombocytopenia, then microangiopathic hemolytic anemia, fever, renal dysfunction, and fluctuation neurological deficits. The findings of thrombocytopenia and microangiopathic hemolytic anemia should raise suspicion of TTP HUS in the absence of other identifiable causes. Then patients with the autosomal recessive inherited ADAMTS13 deficiencies have relapsing TTP. And diarrhea, usually bloody diarrhea and abdominal pain often precede then this HUS. And marked renal dysfunction usually occurs in HUS, so it can help in differentiating between HUS and TTP. Then TTP and HUS, in peripheral smear, we can get fragmented results of schistocytes and thrombocytopenia. And these other findings like anemia, elevated LDH, elevated reticulocyte count, and low or undetectable factor warming up. This kinds of questions of hemolysis. And sporadic TTP will have the same findings as in also as the original TTP, along with the normal PP and APTP values, mild to moderate azotemia, very low or undetectable ADAMTS13 enzyme activity, and other detectable inhibitory antibodies. And typical hemolytic anemia syndrome has acute renal failure and E. coli in stool culture. E. coli stool culture has a higher sensitivity than hevatoxin assays. However, stool samples obtained from after diarrhea has resolved the residue of both tests. So, in the absence of precipitating risk factors, testing for atypical HUS should include molecular and serological tests for complement regulator factor H and I mutations or autoantibodies through reference laboratories. So we don't know whether it's available or not. And coming to infection-related thrombocytopenia. So infection-induced thrombocytopenia is usually involved by these many viral and bacterial infections result in thrombocytopenia and are most common non-hypergenic causes of thrombocytopenia. So this may or may not be associated with the lab evidence of DICs, which is mostly commonly seen in patients with the systemic infection with the gram-negative bacteria and seen in patients who are ill with the COVID-19 infection. So infections, because now in COVID-19 patients, a lot of patients submitted in COVID-19 ward, we can see DIC and all. So infections can affect both platelet production and platelet survival. In addition, immune mechanisms can be at work causing infectious mononucleosis and early HIV infection. So we can see for HIV, we have said earlier. Now, immune-mediated thrombocytopenia in children usually follows a viral infection and almost always resolves spontaneously. This association of infection with the immune thrombocytopenia perfida is less clear in adults. Okay, shall we move on to the slide? The drug-induced thrombocytopenia is one of the most commonly seen thrombocytopenia in our clinical practice. Many drugs have been associated with the thrombocytopenia. A predictable decrease in platelet count occurs after treatment with many chemotherapeutic drugs due to bone marrow suppression. So all drugs should be a suspect in a patient with thrombocytopenia without an apparent cause and should be stopped or substituted if possible to find out the cause. Then, although not as well studied, herbal and over-the-counter preparations may also result in thrombocytopenia and should be discontinued in patients who are thrombocytopenic. So this is the list of drugs reported as definitely or probably causing isolated thrombocytopenia. Is given in Harrison. Mostly, as we can see, acetaminophen, amiodarone, amlodipine, ampicillin, ceftriaxone, ciproflox. So most of the drugs we used to give in our practice, it can cause thrombocytopenia, diazepam, Lasix, and heparin, ibuprofen, lorazepam, naproxen, penicillin, phenytoin, piperazine, piptas, we used to give for most of our patients in ICU admission. Then quinidines, ranitidine, then vancomycin. So all these drugs are reported as definitely or probably causing isolated thrombocytopenia. Classic drug-dependent antibodies are antibodies that react to specific platelet surface antigens and result in thrombocytopenia only when the drug is present. So many drugs are capable of inducing these antibodies, but for some reason they are more common with the quinine and sulfonamides. Drug-dependent antibody binding can be demonstrated by lab assays showing antibody binding in the presence of, but not without the drug present in the assay. But thrombocytopenia typically occurs after a period of initial exposure, median length is usually 21 days or upon re-exposure, and usually resolves in 7 to 10 days after drug withdrawal. Then the thrombocytopenia caused by GP2B3 inhibitory drugs such as abscessimab differs in that it may occur even within 24 hours of initial exposure, in contrast to other drugs. This appears to be due to the presence of naturally occurring antibodies that cross-react with the drug bound to the platelet. Now, coming to the heparin-induced thrombocytopenia. The drug-induced thrombocytopenia due to heparin differs from that seen with other drugs in two major ways. So, first one, the thrombocytopenia is usually not very severe, with the counts rarely going below 20,000. Then heparin-induced thrombocytopenia is not associated with the bleeding as we expect, and in fact, it markedly increases the risk of thrombosis. The pathogenesis of heparin-induced thrombocytopenia is complex. It results from antibody formation to a complex of platelet-specific protein, platelet factor, TF4, and heparin other like Sequestration. So it can occur after exposure to either low molecular weight heparin or fixing as well as unfortunate heparin. So it is more common with our usual unfortunate heparin than the low molecular weight heparin. So most patients usually develop it after exposure to heparin for a 15 to 5 to 14 days. It occurs before 5 days in those who are already exposed to heparin in the prior few weeks or months, approximately 100 days, less than 100 days, and have circulating anti-heparin or PF4 antibodies. Rarely, thrombocytopenia and thrombosis begin several days after all heparin has been stopped. It is termed as delayed onset hit, and more rarely, spontaneous hit or autoimmune hit occurs when there is no history of heparin exposure and termed vaccine-induced immune thrombocytopenia and thrombosis is very rare. A syndrome similar to spontaneous hit has been described rarely post-COVID vaccination, mainly with the N-COVID vaccine. Now, the 4Ts have been recommended to be used in diagnostic algorithm for HIT. The 4Ts are thrombocytopenia, timing of platelet count drop, thrombosis, and other sequelae such as localized skin reactions and other causes of thrombocytopenia not evident. The application of the 4T score system is very useful in excluding a diagnosis of HIT, but will result in overdiagnosis of HIT in situations where thrombocytopenia and thrombosis due to other etiologies are common, such as in the ICUs. So, lab testing for HIT, actually, the HIT antibodies, that is PF4 antibodies, can be detected usually by two types of assays. The most widely available for us is the ELISA with the PF4 complex antigen. Many patients develop antibodies, but do not develop clinically HIT. This test has got low specificity. And the other assay is a platelet activation assay, most commonly the serotonin release assay, which measures the ability of the patient's serum to activate platelets in the presence of heparin in a concentration-dependent manner. This test has also got a lower, lower sensitivity but higher specificity than the ELISA. So, but even though we have got this ELISA and the serotonin release assay, the clinical diagnosis is the mainstay of diagnosing HIT. Now, HIT usually, as we have said, it usually develops in 5 to 14 days of heparin exposure, and is typical onset HIT. Then exceptions include delayed onset HIT, which occurs after stopping heparin, and early onset HIT, which starts within the first 24 hours of heparin administration in patients with the recent exposure to heparin. So we can suspect HIT when thrombocytopenia occurs during heparin exposure by any route in the absence of other causes of thrombocytopenia. 4T scoring system determines HIT predictors probability and has a negative predictive value of more than 95%. And as we have said earlier, it rarely causes severe thrombocytopenia, that is less than 20,000, and when thromboembolic complications occur in 30 to even 75% of HIT patients. Okay. Now, HIT causing venous thrombi at a heparin injection size produces full thickness skin infections, sometimes in the absence of thrombocytopenia. It can cause systemic allergic responses following an IV bolus of heparin characterized by fever, hypotension, dyspnea, and cardiac arrest. So, whenever we give this heparin bolus, we can look if there is any systemic allergic responses like fever, hypotension, dyspnea, and cardiac arrest, especially in cardiac patients, and can suspect HIT. Now, coming to some rare varieties of thrombocytopenia, that is gestational thrombocytopenia. Here, the previous count will be usually more than 70,000. It's a benign mild thrombocytopenia associated with pregnancy. To distinguish between gestational thrombocytopenia and other symptoms, diagnostic testing includes an evaluation for infections, as we have said earlier, and hypertension, and lab testing for hemolysis and liver dysfunctions. Then other causes for thrombocytopenia during pregnancy include ITP, eclampsia, helps with Itp, and as we said earlier. Now coming to post-transfusion purpura. So it's another rare syndrome characterized by the formation of alloantibodies against platelet antigens, most commonly HPA1. HPA1 follows hormone transfusion and causes severe thrombocytopenia, as usually less than 15,000 within 7 to 10 days of transfusion. The confirmation is by detection of platelet allo antibodies.
Okay, link is going to expire. I'll create another link and we can
Okay,
start
okay.
the discussion.
Okay.
Okay.
Now rule out the most common causes we have to rule out.
Okay.
And especially this drug-induced thrombocytopenia, then this infection-related thrombocytopenia.
Okay, in short, what will be your clinical approach to thrombocytopenia? Whenever you see thrombocytopenia, how will you proceed?
We will take his proper history.
Okay. So history, when will you suspect thrombocytopenia? Usually, thrombocytopenia will be a lab finding, but can you predict that the patient may have thrombocytopenia from history?
Patient can present with bleeding
History of
manifestations.
bleeding
Petechia, ecchymosis, everything
Purpura.
about purpura.
Purpura is
All those
usually
are-
not a symptom of thrombocytopenia. So what you told was right only. So from the type of bleeding, you can differentiate. So any patient who has a bleeding, our aim is to differentiate whether it is a vessel wall disorder, a platelet disorder, or a coagulation disorder. So these three have distinct clinical features. For example, can you name one vessel wall disorder? Hereditary hemorrhagic telangiectasia.
Okay.
So where the blood vessels are exposed under the skin or in the mucosa, there the bleeding will be more. So epistaxis is the commonest symptom of hereditary hemorrhagic telangiectasia, which is a vessel wall disorder. Now, for thrombocytopenia, hereditary hemorrhagic telangiectasia, HHT.
Okay.
And the one which you projected in the slide, no symptoms. That is especially in the lower limbs only, thrombocytopenic manifestations come.
Okay.
This one. Yeah, the areas of increased venous pressure, ankles, feet. So petechia and ecchymosis. Okay, it is not purpura. Purpura is a sign of an enlarged vessel. So it is usually occurs in vasculitis. So this Henoch-Schönlein purpura, IgA vasculitis, all these conditions will cause a dilated blood vessel. Purpura is palpable. So when you are seeing a palpable purpura, it is not due to thrombocytopenia. When you are having a non-blanching flat lesion, okay, it is not an elevated lesion. A pinpoint non-blanching flat lesion will be petechia. That points towards a thrombocytopenia.
Okay. Pinpoint non-blanching.
Yeah. Pinpoint non-blanching hemorrhage. Suppose if it is larger in area, we call it as ecchymosis.
Okay.
Next comes oral mucosal bleeding, nasal mucosal bleeding. So all those mucosal bleedings, again think of thrombocytopenia. I mean platelet disorders. The last category which I told you is a coagulation disorder. In coagulation disorder, intramuscular bleeds and intra-joint bleeds are more common. So you know very well hemophilia, patient presents with hemarthrosis and muscle hematomas, retroperitoneal bleeding. Such large cavity bleeds are more common with hemophilia. So it is not that one cannot present in another way. So obviously, even a severe thrombocytopenia can cause intracranial hemorrhage, but it is more likely with the hemophilia, a cavity bleed. So this is how the symptoms come. Next thing is ask the duration of the symptom, because in your approach also, in your clinical approach also, Firdause summarized that the first thing you have to rule out is the treatable or reversible causes of thrombocytopenia, like a drug-induced thrombocytopenia infection-induced thrombocytopenia, which are reversible. So, bleeding manifestation presenting first time after a fever, it lasted for a short time. It's mostly an acute condition, which is a reversible one. Whereas any past history of bleeding, it cannot be an acute one. So, it has to be a longer duration.
Okay.
So, for any hematological disorder, especially for bleeding disorders, the age at onset, the duration of the symptom, and the pattern of bleeding. These three are the very important histories which can differentiate everything. For example, I'll give you a scenario, you can predict what it could be.
Okay.
20 years old male comes to you. He had his first bleeding episode at the age of 5 years. He has had 7 or 8 admissions for bleeding till now. All the bleedings were joint bleedings. Can you predict what disorder this could be? Yeah, male X-linked, young age of onset, recurrent. So it's an inherited coagulopathic disorder, probably hemophilia. Okay, so now another patient comes at female, comes at 35 years of age with nasal mucosal bleeding. She had similar episodes of nasal mucosal bleeding at the age of 25 years. It resolved with treatment. Now comes again. Young age female, 10 years duration, probably ITP. Because this is a thrombocytopenic symptom. So this seems to be a platelet disorder, acquired platelet disorder, which is recurrent. And it had improved with the drugs. So probably ITP. Now, same 25 years old female, or take a male patient, a 25 years old male. His first bleeding episode was since 3 years of age. He had had 3 or 4 admissions till now. The manifestation will be petechiae as well as bleeding gums.
Okay.
What this could be?
Petechiae and bleeding gums.
Yes. No, don't make it very complicated. The age of onset is 3 years, pretty early age. So we can, it could be an acquired or it could be a congenital, inherited. So let's take it to be an inherited. Is it a platelet disorder or a coagulopathy disorder? You are not audible.
Firdause, bro, we can't hear you at all. Very low volume. Hello? Firdause? Firdause? He left.
He is online only. Probably he is searching a better microphone.
Can you pause the record, sir?
Okay. If you are very complicated with what it could be, at least you are now clear that it is a congenital platelet disorder, right?
Yeah.
In inherited platelet disorder. So we have a list of inherited platelet disorder, be it a platelet number disorder, like a von Willebrand disease is a platelet number disorder. Whereas Bernard-Solier syndrome, Glanzmann thrombosthenia, these are disorders of platelet function.
Okay.
So the simple history, what is the site of bleed, the age of onset, and the actual progress, whether it is recurrent or whether it is subsiding, will give you a clue whether it is inherited or an acquired disorder, a platelet disorder or a coagulopathy. And plus we can make some meaningful conclusions from that before the actual evaluation starts.
Okay.
So this is about the clinical features. Then, okay, what is the most common cause of thrombocytopenia?
Thrombocytopenia.
Most common
Is it
cause.
drugs?
In one slide he mentioned drug, in another slide he mentioned as infection. So
Actually, drugs are the most common cause of iatrogenic thrombocytopenia. Infections are the most common cause of non-nitrogenic thrombocytopenia.
Okay, so taken together, infection and drugs. That is, secondary causes are the most common cause of thrombocytopenia. So this is meaningful. The most common cause of thrombocytopenia overall is infection, but iatrogenic thrombocytopenia is drug. And you told that the most important drug is heparin.
Okay.
So can you clinically correlate the importance of heparin-induced thrombocytopenia?
Clinically,
Yeah, clinically. Because all these, say, why do you have to evaluate thrombocytopenia? If platelet is low, we can very well give platelet transfusion and we can send the patient home. Why to evaluate the cause? Finding ITP has a meaning because treatment is different. We can give steroids and recover the patient. In infection like dengue, it is very important because the dengue, as per dengue management protocols, dengue fever with any bleeding manifestation, irrespective of the platelet count, we have to transfuse platelets. Or
with the bleeding manifestation,
with the bleeding manifestation, irrespective of the platelet count, we have to transfuse platelets. Or platelet count is less than 10,000, even if there is no bleeding, we can transfuse. So these are the only two indications for platelet transfusion in dengue.
Okay.
dengue.
Platelets less than 10K or
10K
with
or
bleeding manifestation,
any
irrespective of count.
Bleeding manifestation with any count of platelet.
Irrespective of the platelet
count.
Yes. And
Okay.
for surgery also platelet has some implication because for few procedures we need a few target platelets. So for minor procedures 30,000 is the count. For major neurosurgical procedures 80,000 is the required count. So at least 1 lakh. Okay, so less than 1.5 lakh is thrombocytopenia, but at least 1 lakh is needed for any major surgery. But actual book references say 80,000 platelet count is sufficient.
Sure.
So these are the actual implications why we should know about platelet. But why should you classify? What's the importance of finding it is TTP, it is HUS, or it is just a drug-induced thrombocytopenia, so and so.
One thing is treatment.
We should know whether it is a destruction problem or a production problem.
That's the actual approach to come to a diagnosis. That's what he classified into 4, right? So one is it could be a problem with the platelet production, or it could be a problem with platelet destruction, or something intermediate between that is platelet sequestration. Infections can cause thrombocytopenia by Hello.
Okay, my doubt was
Hello.
Can you explain that sequestration? Okay, after you finish.
Okay, I'll tell you. And infections can cause thrombocytopenia by both the mechanisms. It can reduce the platelet production by affecting the bone marrow, or it can cause an autoimmune destruction of the platelets. So both are possible.
Okay.
Okay, so I'll just explain this slide and we'll proceed the discussion. So decreased platelet production, it is very easy to understand. Either congenitally or acquired, the bone marrow is not producing. So congenital disorders will be marrow failure syndromes like Fanconi syndrome, etc. Acquired will be the most common is aplastic anemia or marrow infiltration disorders like hematological malignancy or a non-hematological malignancy invading the bone marrow or a granuloma. For example, tuberculosis of the bone marrow, right? Some granulomatous infection, myelofibrosis, etc. So all these are disorders of platelet production. Platelet clearance, again, it is very clear. Platelet is produced in normal amount initially, but something destroys the platelet in the blood. Or, so every cause is obvious. So immune thrombocytopenic purpura, there is antibody against the platelet. Platelets are getting destroyed. Thrombotic thrombocytopenic purpura, there is a diffuse problem with the endothelium. Okay, so the endothelium consumes more platelets in the form of coagulation. So there is more amount of thrombosis going on in the blood. So because of all this consumption, the platelet count in the body reduces. That's why this disorder is called as consumption coagulopathy.
Okay.
DIC is also a consumption coagulopathy. So anything, any syndrome, any infection which damages the endothelium throughout. In the lung, it is going to cause ARDS. In the blood vessel, it is going to cause diffuse endothelial damage. And you know very well that platelet is the first agent to go and repair that endothelial damage by sealing the blood vessel. He mentioned in the first slide, 5,000 to 10,000 platelets are needed to maintain normal vessel wall integrity. So to maintain that integrity, in response to this endothelial damage, everything goes and settles there and it tries to form a thrombosis. So both thrombosis and bleeding occurs with DIC, TTP, HOS, etc.
So actually, this happens with this aortic aneurysm also. No?
Yeah, aortic aneurysm, when it is large, definitely due to shear stress, some amount of damage will be there. So it will cause thrombocytopenia. Splenic hemangioma. Splenic hemangioma also, there will be local accumulation of blood. Platelets will be sequestrated.
Okay.
Okay.
Okay, so this is about increased platelet clearance. And sequestration is nothing.
One doubt. One doubt. This nutritional causes are there. No, it's, as we can see in this slide.
B12 and folate.
So whenever a patient comes with thrombocytopenia, we can send for vitamin B12 and folate levels. No.
Yes, we can send.
Okay.
It has another implication. Usually B12 and folate deficiencies cause pancytopenias.
Yeah.
Okay.
That you have mentioned another slide. We'll have a discussion on that also.
Yeah.
And sequestration, for Daniel, for your question, sequestration is spleen is the organ which engulfs platelets, right? It destroys the dying blood cells. So when the spleen is more enlarged, it takes more of blood within it. It hyperfunctions. That is what is hypersplenism. So any condition causing hypersplenism. So portal hypertension will cause splenomegaly. When the enlarged spleen is functioning more, it will catch more of blood and try to destroy it. That is what is called a sequestration.
Okay.
If
So it
is
hypersplenism.
sequestration, no. All cells will be affected, no?
All cells will be affected. But the cell which is most commonly affected will be platelet.
Okay.
In MICU now we are having one patient, right? He is having platelet count of 75,000. It's a case of DCLD.
Case of DIC.
DCLD, portal hypertension.
So there is splenomegaly. In turn, platelets are low. Okay, what about the other cell?
Other cells will be low. See, what is the definition of hypersplenism?
Hypersplenism
is the reduction in 2 or more cell lines.
Okay.
There should be enlarged spleen with the reduced 2 or 3 cell lines. It should be reversible by splenectomy. This is the criteria to say hypersplenism.
Enlarged spleen plus reduction of 2 or more cell lines.
Yes, if only platelet is reduced, we cannot call it as hypersplenism. To say hypersplenism, we need at least 2 or 3 cell lines to be affected. But even if one cell line is reduced, of course, enlarged spleen could be a possibility.
Possibility.
So that patient, MIC patient, no, he's having hypersplenism, no?
No, that's what I'm telling. If he's having anemia also, no? Yes, he is having hypersplenism.
He's having anemia and ultrasound. There is hepatosplenomegaly, no?
Yeah, there is splenomegaly for him. One criteria done. He's having anemia plus thrombocytopenia. Second criteria done. Now, after splenectomy, if it reverses, then we can say hypersplenism, but we need not do splenectomy for him. So clinically, we can label him as hypersplenism.
So for call just hypersplenism, we have to do splenectomy, no?
Yeah, that's the actual criteria. Why this is important? Why knowing the splenic sequestration is important? Because if you leave off this splenic sequestration, we have only 2 categories. No, one is the decreased production, another is increased destruction.
Yes.
These are two broad
Yeah.
categories. So, frankly speaking, splenic sequestration is also peripheral destruction like only. It is the bone marrow production is normal. There is a proliferative response
Yeah.
from the bone marrow. Even that some say as a
Yeah.
criteria for hypersplenism. The bone marrow hyperproliferative response should be there in hypersplenism. So if you do a bone marrow in a patient with hypersplenism, there should be increased megakaryocyte count due to increased production.
Okay.
So
Yeah.
logically speaking, this splenic sequestration is also a disorder of platelet destruction. But
Yeah.
why it is taken as a separate entity?
Because the whole scenario changes. We don't know.
The problem comes with Felty syndrome. What is Felty syndrome? Not only with Felty syndrome. Assume a patient with systemic lupus erythematosus or a patient with extramedullary hematopoiesis. I think we can discuss extramedullary hematopoiesis. In patient with extramedullary hematopoiesis, the bone marrow is getting infiltrated. Okay, the bone marrow is getting infiltrated. So the spleen enlarges in size to take over the hematopoietic function, right?
Okay.
Yeah, that is the actual mechanism which is happening. So this is
Okay.
said to be a splenic sequestration, but it is not hypersplenism. Because the spleen here, it is not destroying the blood cells, it is producing blood cells.
Okay.
Producing. So for this patient, if you do a bone marrow, we cannot find out increased megakaryocyte. We'll have a reduced megakaryocyte only because bone marrow is infiltrated by the primary pathology.
Okay.
So in a patient with the pancytopenia and splenomegaly, it is always a difficult challenge because two possibilities are always there. The primary pathology is the splenomegaly causing hypersplenism, causing an just a minute.
Yeah. Yeah. Recording. Yeah.
I'm back.
No.
Yeah. Okay.
Okay. So in
Pancytopenia with
pancytopenia with hypersplenism, these are the two gross possibilities. One, the bone marrow may be the primary pathology, and the spleen is enlarging to trying to compensate for this one. In that case, the bone marrow will show an infiltration only. It will not show a megakaryocytic response. Whereas if it is a hypersplenism, the thing is different. The bone marrow will be producing excess megakaryocyte. So the diagnosis will change in both, right? Because if it is a primary hypersplenism with the pancytopenia, you have to treat the primary etiology. We have to do a splenectomy.
Okay.
Whereas if it is an extramedullary hematopoiesis due to primary marrow infiltration, things are different. You have to treat the bone marrow. So that is why it is given as a separate entity. So platelets are reducing due to reduced production. Platelets are reduced due to increased destruction, and the separate entity of bone marrow and the spleen. It's like a love story.
So whenever there is a patient with splenomegaly and this pancytopenia, we have to do bone marrow study now.
It is ideal because we don't know both. See, suppose if the diagnosis goes like this, is a case of chronic liver disease with cirrhosis, with portal hypertension and splenomegaly, the clinical diagnosis itself is obvious that he is going to have a hypersplenism. But suppose a patient comes in between. His first presentation itself is a pancytopenia. His liver is normal. There is no cirrhosis, no portal hypertension, but just a splenomegaly. In this case, we do not know.
Okay.
In this case, we do not know. Because a young age male with splenomegaly, we have so many other causes, right? Splenomegaly, we can discuss in another topic. But in short, we have six gross causes of splenomegaly. One is the local causes, like the liver disorders can cause splenomegaly. What else to say? RBC disorders can cause splenomegaly. Whatever it is the cause of splenomegaly, the question in this case will be whether the splenomegaly is causing the pancytopenia or the pancytopenia is causing splenomegaly. Treatment is different for me. Okay. And this answered Daniel's question. Now about infection, the one thing I want to know is infection will cause thrombocytopenia by both the mechanisms.
Yeah.
So dengue can affect the bone marrow and cause reduced platelet production.
Okay.
Do you agree on this?
First time I'm hearing.
And how dengue can affect bone marrow?
Dengue causes reduced total count before the platelet count, right?
Okay.
Okay.
Yeah.
That's it.
That's the evidence. But
Oh.
another mechanism is dengue produces autoantibodies against the platelets, so increased platelet destruction.
Okay.
Okay, this also has a clinical implication to differentiate because I proposed this as one of my thesis topics, but it got rejected unfortunately. Okay, 10 minutes la mudiyuma. Okay, I think another third link also we had to create.
Oh.
Okay, no problem.
No problem.
So, okay, we can
Knowledge is
continue.
power.
Yes.
Yeah.
Okay, so why this is important is in case if dengue is causing thrombocytopenia by reduced marrow production, in that case giving platelet is ideal. Am I right?
Once more. Can you repeat that, please?
If dengue or an infection is causing thrombocytopenia by affecting the bone marrow, the production from the
Okay.
marrow itself is less. So we must give platelet transfusion in that patient.
Okay. Yeah.
Whereas,
Agreed.
whereas the same infection like a dengue is destroying the platelets outside, will it be much benefited by platelets?
It won't.
Because if you are giving platelet again, it will be destroyed by the antibodies.
Like ITP.
Like ITP. So now my question, that is the actual question which I asked you initially. What is the clinical implication of knowing why you have to differentiate the different types of or different causes of thrombocytopenia is
Okay.
there are 3 definite contraindications for giving platelets in thrombocytopenia. So not all thrombocytopenia we have to give platelets. So what are the 3 indications where you should not give platelets?
ITP.
ITP is a doubt. Okay, because whenever it is low, time being for stabilization, we can give give platelets. But logically speaking, ITP also you should not give. There won't be much benefit.
Okay.
But the absolute contraindication is TTP.
Thrombotic thrombocytopenia.
Because if you give platelets, more thrombosis
There'll be
will
more
occur.
thrombosis. Yes.
HIT you should not give. Already there is thrombotic thrombocytopenia, as Firdause explained beautifully. Heparin is going to cause thrombosis rather than a thrombocytopenia. If you are giving more platelets, it will cause more of thrombosis.
More of thrombosis.
Similarly, in DIC, you should not give platelets.
DIC. Yeah.
So
basically, all 3 have similar mechanism.
Yes. So DIC, HIT, and TTP, these are the 3 absolute contraindications for giving platelets. So
Actually, in DIC, no. Sometimes we used to give FFP and all, no?
FFP can be given, not platelets.
FFP is given. The platelet one.
Platelets.
Okay, so that is how we have to differentiate. So coming back to the dengue thing, so how to differentiate whether it is a marrow hypoproliferation or it is a peripheral destruction, be it infection or any cause. Without
One is
marrow,
we can see which reduced first, total count.
one is the
How is that?
associated features.
Okay.
That's what was given in another slide. The approach from Harrison says if platelet count is low platelet count is associated with bicytopenia or a pancytopenia, definitely we must do the bone marrow examination. Okay, so bicytopenia or a pancytopenia, if it is not due to transient reversible causes like a drug or infection, bone marrow examination is must. Whereas if it is an isolated thrombocytopenia, then the approach is different.
Okay.
Okay, so one thing.
So basically, pancytopenia, bone marrow.
Yeah.
That's what you said, right?
And another thing, hypersplenism.
Okay.
Actually, in this pancytopenia, it can happen in DAC and all, no?
Pancytopenia in
Pancytopenia,
DIC, not much.
less.
Thrombocytopenia is definite.
Not pancytopenia. Okay. Then anemia and all can happen.
The pancytopenia is a different entity. We can discuss that later because it is a discussion on its own. Okay.
Okay.
Splenomegaly, pancytopenia, everything is a separate topic.
Yes. Spleen is
We
a
can
very
have
big
one.
discussion, but all these are confusing discussions. If you are masters of that, you can treat many complicated issues well.
Okay.
Okay. So what else?
Another doubt
So now,
hello.
Yeah.
yeah, tell.
What is mean platelet volume?
Mean platelet volume.
Uh,
The average
Volume
volume
of platelet.
okay, the volume of one platelet. So nowadays, a few parameters are gaining increasing popularity. One is MPV, mean platelet volume. Next is
Okay.
PDW, platelet distribution width. Like Ritzel distribution width, we have platelet distribution width.
Oh,
Next is IPR, immature platelet cell ratio. Sorry, platelet large cell ratio, PLCR. PLCR, platelet large cell ratio. So what all these things mean is mean platelet volume indicates the average size of one platelet. So if the platelet is large, it means that bone marrow is producing more of platelets, more of precursor platelets. So this again confirms peripheral destruction.
1 second. Platelet large, bone marrow producing more. So
Precursors.
confirms peripheral destruction.
Yes.
Clear?
So if the MPV is normal value or in the lower range, it means bone marrow is hypoproliferated. It is producing smaller platelets.
Okay.
This was my thesis topic. In dengue fever, by seeing MPV, we can predict that whether there is a peripheral destruction type of thrombocytopenia or a bone marrow suppression type of thrombocytopenia. If it is a peripheral destruction, we should not give platelets. It will have no effect in dengue fever.
Okay.
In that case, we have to give steroids.
So if in dengue fever MPV is normal or low, then we can do bone marrow study or bone marrow suppression.
Not bone marrow study because it is a transient one only, no. But treatment wise, we can confidently give platelet transfusion, assuming that it will not improve. But the the first category I told, no, peripheral destruction, high NPV, it will respond to steroids.
Okay.
Similarly, only other parameters like platelet distribution width, if it is high, means many different size cells are produced. So bone marrow is hyperproliferated. So high PDW, peripheral destruction. Low PDW, marrow hypoproliferation. Okay. Similarly, PLC, platelet large cell ratio. If large cells are more, it means marrow is producing more. So peripheral destruction. If PLCR is normal, it means marrow production is less. So these are the non-invasive.
Normal, marrow production less.
Less.
PLCR full form, can you repeat?
Platelet large cell ratio.
Platelet large cell ratio. What was the other thing? PLD.
PDW, platelet distribution width.
In our hospital, it's not available. In some other advanced counters, it is available.
Okay. So this will be pretty useful. Mean platelet volume that we do here.
Yes.
So
and it's a very non-invasive also.
Very non-invasive.
If you see the two thrombocytopenia patients admitted in our hospital last week, both had a high MPV. So with just by seeing that value, you can confidently say that the marrow is hyperproliferating. So it was an evidence which helped us to confirm that it was IT, even before a bone marrow. Okay.
So there was peripheral destruction happening.
Yes. Okay, only 1.26 minutes more. I'll close this and we'll create another link. Only 10 more minutes we'll discuss and close today.
Okay.
Get ready with all your doubts.
Okay.
Okay. Continue with your other doubts.
Oh.
10 more minutes.
Okay. So
At the end, we'll
basically
summarize
you
what
said
all we
about-
learned.
Okay.
Hmm.
So history you said.
Hmm.
It's important. Duration of symptoms of bleeding, age at onset, pattern of bleed will give you an idea whether it is inherited or acquired, or whether it is a platelet problem or a coagulopathy problem, right?
Yes.
And then we were talked about dengue. Okay. First, you said something. No, three things. Clinical features, whether you can find out whether it's a vessel wall disorder. Then you said the second one you said is mucosal involvement.
Platelet disorders
And
usually cause petechiae and ecchymosis and mucosal bleed. Vessel wall disorder will cause mostly mucosal bleeds only. It will not cause other bleeds. Mucosal bleeds, melena, etc. A coagulopathic disorder will cause muscle hematoma, retroperitoneal hematoma, joint bleeds, and cavity bleeds.
Okay.
So vessel wall will cause mucosal and
Vessel wall is mainly mucosal.
Mainly mucosal.
Platelet
and
problem will cause coagulation
platelet
disorder
problem
will cause
mainly petechiae.
intramuscular intra-joint.
Joint, mainly joint. Some
And
5
platelet will
points,
cause
5 or 6 points of differences will be there. Many differences, but these are the main differences.
okay, a platelet will cause all these petechiae and all, right?
Yes.
Petechiae and mucosal also.
Mucosal
Yes.
also.
Mucosal. So if patient is having both, then you can confidently say that it is platelet related disorder.
Okay, that is a good point.
And
That bed number 4. No, there was one 17 or 20-year-old boy was there. No,
yes.
Oral mucosal bleed.
Oral
And
mucosal
he is
bleed,
having
hematuria, and skin bleed.
And skin
Okay.
bleed was there. So it is platelet only, no?
It's platelet.
Platelet, yeah.
So
It
just
is
by the
mucosal
history
alone?
itself, we can.
Yeah. Sure. So that is one good point.
So vessel wall mainly mucosal only, no? Right? Any other thing?
Mainly mucosal
But
only.
that
The presentation will be
manifestations
epistaxis only.
Presentation will be different.
Oh.
Then what is 4T score?
4T.
Yes.
That is in heparin-induced thrombocytopenia.
Yeah.
We look for thrombosis. We look for thrombocytopenia, definitely.
Thrombocytopenia.
I have downloaded.
Okay.
I have downloaded that score, but no. Actually,
It's here.
I could not. It's here. Actually, there was a table.
Oh. Okay.
Okay, you can read that 4T score. They may ask you this in exam.
T score. Okay. Okay.
The thing is, heparin-induced thrombocytopenia usually occurs after stopping heparin. Usually, in our hospital for MI patients, we give heparin for 5 days. But heparin-induced thrombocytopenia occurs from 5th day to 14th day. So we will not suspect thrombocytopenia due to heparin. We will be thinking as some other cause, but it will develop on day 6 or day 7.
Yeah.
Okay.
And
So,
you should not give platelets.
No use of giving platelets. Yeah.
Yes. Not no use. It is contraindicated. It will worsen.
Not no use, it contraindicated. Okay, I'm sorry. Yeah.
So
what is the treatment actually? Steroids.
Heparin-induced thrombocytopenia.
How
You
do
have
you
to
treat?
stop heparin. First thing is you have to stop heparin.
Suppose you already stopped, it came later on, then nothing
Nice
to do.
question. Observation.
Okay.
Actually, no. This patient having who require anticoagulation, no. With the hit, no. We can start on this novel oral anticoagulants, no.
Fondoparinox, LMWH, they do not they have carry a very risk.
Fondaparanus we can give.
Fondaparinux definitely can be used, but compared to
Okay.
heparin, LMWH may be used. It has a less risk. Fondaparinux does not have the risk, so you can change it to that. Because
Yes.
especially if HIT is associated with thrombosis, in that case, fondaparinux can be used.
Okay.
So whenever a patient with the recent history of MI and all coming with the bleeding, we can suspect it.
MI with the
Yeah.
bleeding, we may suspect.
MI.
We can suspect definitely a patient with a history of blood transfusion now coming with thrombocytopenia. It could be post-transfusion purpura. Patient with COVID vaccination recently coming with thrombocytopenia. It is that VITT, vaccine-induced thrombocytopenic thrombosis.
Yes.
Okay.
Patient with recent heparin intake now coming with thrombocytopenia with some doubtful thrombosis. It is HIT.
Okay.
Patient with diarrhea and thrombocytopenia.
Yeah, and we have read somewhere.
Diarrhea and thrombocytosis.
Yeah, that's the one thing we.
That this thing HUS.
Yes.
Hemolytic uremic syndrome. Yes.
So for any patient who presents with dysentery type of picture, like a bloody diarrhea, always have a look at their hemoglobin
Okay.
Okay.
and platelet. Because if hemoglobin is falling, hemolysis is there. RFT is rising, it may not always be due to the dehydration. It could be this also.
Okay.
Because the treatment is different. If it is a pure dehydration related elevated urea and creatinine, we have to hydrate. But if it is due to hemolytic uremic syndrome, patient is having increased urea and creatinine, in that case, patient may need dialysis, plasmapheresis, and other treatments.
Okay.
So you have to have a careful look at the peripheral smear also. If there is evidence of hemolysis, like increasing bilirubin, elevated LDH, thrombocytopenia, anemia,
Yeah.
you have to think of HUS also.
Yeah.
Oh.
Non-diarrhea HUS, we call it as TTP. It is due to that ADAM-TS13 deficiency.
ADAM-TS13. Yes.
Treatment for both is usually plasmapheresis, supportive care and plasmapheresis.
Okay.
Which is contraindicated?
The
TTP.
platelet transfusion.
Yes.
Platelet.
Transfusion is contract.
Okay. Okay. Just now another question I'll ask you. Pregnancy and thrombocytopenia causes.
Pregnancy, physiologically, it will cause a bit of thrombosis.
He had one slide on that also.
Yeah.
Pregnancy and thrombocytopenia.
Yeah.
Yeah.
Last slide.
This one.
Dilation.
Gestational
Actually,
thrombocytopenia.
recently we have in CC, bed number 1, that just pregnant lady with thrombocytopenia. Okay, that lady was negative positive. I think her count was below 1 lakh only, as far as I remember.
Anyway, you have to look for everything. Because before labeling it as gestational
proper
thrombocytopenia, you have to rule out the dangerous causes.
Yeah, help and all.
Help. So you told about thrombotic microangiopathies, right? TTP, HUS, preeclampsia, all these are thrombotic microangiopathies. Any other thrombotic microangiopathies you know? This is not related to this one, just one additional question. Accelerated hypertension is also said to be a thrombotic microangiopathy.
Okay.
That also causes microvascular hemolysis.
Okay.
Okay, so this is about pregnancy. So next time if someone calls you for a pregnant woman with thrombocytopenia, you should think of all these possible differential diagnoses. The postpartum hemorrhage with thrombocytopenia, it could be DAC. If she develops diarrhea, it could be TTP also. But specific to pregnancy, HELP syndrome, eclampsia, ITP, then last option only should be your gestational thrombocytopenia.
Yes.
Okay, two things.
Yes.
Gestational thrombocytopenia will not persist after pregnancy because it is due to the dilution. But if thrombocytopenia persists after delivery, think of ITP.
Yes.
Pregnancy or a dengue. Usually that's how ITP is picked up. Patient comes to a fever ward with dengue fever, thrombocytopenia, but even after so much of treatment, thrombocytopenia will not resolve. It will be ITP.
Okay.
Similarly, a pregnant lady
Okay.
will be treated as gestational hypertension, but after a long time, still it will be persisting. It will be ITP.
Okay.
Okay. Now the next question: infection with the thrombocytopenia.
Thank you.
Dengue.
Oh,
What is your question?
Dengue.
That's infection and
Causes or?
thrombocytopenia. Not causes. Whatever you think, you tell. One
Infection
is
and
accepted.
thrombocytopenia.
Sorry.
All these infections: HIV, HHV, malaria, dengue.
All
Then
can cause.
Actually, in this list, dengue is not given, but actually, I always tell 6 fevers, right? Undifferentiated fevers. All those things can cause thrombocytopenia. Typhoid fever, dengue, malaria, rickettsia, leptospirosis. Everything can cause dengue. Everything can cause thrombocytopenia. Can bacterial infection cause thrombocytopenia?
Yes.
Sepsis-induced thrombocytopenia.
What
Patient,
Yeah, which one?
any sepsis, any bacterial sepsis.
Any sepsis.
Any sepsis itself can cause
gram-negative bacteria.
thrombocytopenia. Yes.
Okay.
So patient with a total count of 25,000 with some source of infection with thrombocytopenia, if you are not able to find out the cause, we can label it as sepsis thrombocytopenia also.
Okay. Then
But
we can start the gram-negative coverage also, no?
yes.
Yeah.
Indication for treatment. Can sepsis cause thrombocytosis?
Yes.
Reactive thrombocytosis.
Yes. Only we have few causes of thrombocytosis only. Okay. So one among the causes is reactive thrombocytosis. So initially, platelet bone marrow will be suppressed, causing thrombocytopenia. In the later stage, it will cause hyperproliferation, causing reactive thrombocytosis.
Okay. That occurs in sepsis.
Sepsis. Resolving sepsis, maybe.
What are the other causes of thrombocytosis?
That you can refer. First thing, we'll always think of reactive thrombocytosis. Then we have some congenital disorders now. Essential thrombocytosis.
This thing, no. Essential thrombocytosis.
Yes. Those
Okay.
myeloproliferative disorders.
My friend's father is having essential thrombocytosis.
Usually, whenever thrombocytes are high in the bone marrow, megakaryocytes will be more. High megakaryocyte is associated with a high risk of myelofibrosis. So, any disorder in which platelet count is very high, they are in future risk of developing myelofibrosis.
Okay.
Okay, so this is another simple clinical way. So, whenever you are seeing an infection with thrombocytopenia, what are the differentials? Pregnancy with thrombocytopenia differentials, diarrhea with thrombocytopenia differentials. Like that, you can keep on going.
Yeah.
So what else we left? Pseudothrombocytopenia again. Have you seen cases of pseudothrombocytopenia?
No.
I have seen one when I was in PG. Because platelet count alone will be low, but patient was very, very stable. So we sent it in another tube, it became normal.
Okay.
Okay, I'll give another
Actually,
scenario.
Yeah.
Yeah, someone came to ask a question.
That is something we could think of. Pseudothrombocytopenia also. Especially in our lab.
Actually, a lab approach to this one will be like that only. So the etiology based approach to thrombocytopenia, we have to classify it as from bone marrow disorder or a peripheral destructive disorder, because that determines what treatment we should give. But another approach or a practical approach will be whenever there's a thrombocytopenia, when you see in the lab, the first thing you have to see is whether it is a pseudothrombocytopenia or not. Okay, so you have to do investigation 2 times, or you have to confirm with a peripheral smear. That is what it's given. How to confirm pseudothrombocytopenia is by a peripheral smear or a sample repeated from a blue tube or a green tube.
Okay.
Still, if thrombocytopenia is persisting, first thing you have to rule out acute things like a drug-induced thrombocytopenia or an infection-induced thrombocytopenia.
Okay.
Still persistent thrombocytopenia, you have to evaluate whether it is a bone marrow source or a peripheral destructive source and go accordingly.
Yeah, our lab is having pseudo hyponatremia, it seems.
Hypernatremia is a separate class.
Hyponatremia, all patients.
Hyponatremia. Not
So I
only
will have lot of
hyponatremia, everyone is having yeast cells also.
yeast
in
cells in
suputum.
stool, few gram positive cocci and gram negative.
So
scattered.
same standard. I
Standard
think this
report.
is the template.
That is why I'm scared to shouldn't diagnose any patient because everybody will have same disease diagnosis.
And regarding this slide, for any hematological disorder, examination you have to look for two things: spleen and lymph nodes.
Spleen and lymph node.
Okay,
Yes.
because those determine the diagnosis. Because a patient with thrombocytopenia with splenomegaly, I told you the problem with which occurs. Can ITP have splenomegaly?
It can.
ITP will not have splenomegaly.
Oh.
That is the thing. ITP should not have splenomegaly. If splenomegaly is there, it is probably a case of sequestration. Even I made a mistake this here. My senior only taught me splenomegaly will not occur in ITP. Can splenomegaly occur in aplastic anemia?
No,
How?
Yes.
It cannot occur.
it cannot occur.
It cannot occur because there are no hematopoietic
Nothing
stem
to.
cells to migrate and cause extramedullary hematopoiesis.
Hmm. Okay.
Okay, so we have discussed the symptoms. We have discussed the examination part. Lab parameter, how to approach we saw. The four etiological categories we saw. Then the Harrison approach we discussed. ETP we didn't discuss much because one thing, most important thing is look for secondary causes of ITP like ANA. You can send an ANA profile. You can send a viral marker profile. Okay, so for any hematological disorder, never forget to send a viral markers HIV, HBsAg, HCV, and
Okay.
never forget to send ANA profile.
Why?
Okay.
Secondary ITP, SLE can cause ITP.
Okay.
See, for ITP, we usually send Coombs test, right?
Yes.
Coombs is something associated with RBC. For a platelet disorder, we send Coombs test to identify associated hemolytic picture, hemolytic antibodies.
Okay.
Because for ITP, we have antibodies, but we usually do not do. It's not very specific. So ITP is only a clinical diagnosis of exclusion. If no other causes find out, we are having a proliferative response from the bone marrow, then we can suspect ITP. But bone marrow as such is not needed to confirm ITP.
Sure.
Okay, that is very important. So if someone asks without bone marrow, how can you say ITP? Now we can tell, we can, based on the associated clinical findings of elevated MPV, absence splenomegaly, we can tell that it is ITP. Bone marrow is not mandatory.
Okay.
And TTP we have discussed.
Thrombocytopenia, we have to send the ANA profile also. No? If any
Yes,
other
yes. Secondary ITP to be ruled out. Infections, drugs. Practically any drug is causing thrombocytopenia, right? Even this slide is new to me.
Yeah, anything can
No,
cause
Harrison.
Rantac, furosemide, haloperidol.
classics.
Piptas, our universal drug, Piptas is causing thrombocytopenia.
What else? Lasix. Without Lasix, we cannot live in ICU.
I see.
Lasix and Piptas, no. We have run our ICU by Piptas and Lasix only.
But no
And
patient is
also-
having thrombocytopenia here. Now we can publish a study that this is wrong.
And also amlodipine. First drug we give to all hypertensive patients.
Yes.
Any medical
Ampicillin.
officer will give only amlo, no?
Okay.
Ampicillin also.
I told you about VITT, vaccine-induced thrombotic thrombocytopenia.
Yeah.
Okay. So I think I have covered all the aspects which you have presented. So can one of you just summarize what all you learned?
Daniel.
Buddy, do you want to spoil this class?
I presently know you, the summaries man.
Okay, so we first studied about clinically, based on history and all, how you get a clinical picture of to narrow down the cause of thrombocytopenia. So, or whether is it first of all, whether it's a platelet function or a coagulation problem function problem. So you ask the from history, you basically ask the duration of symptoms, age at onset, pattern of bleed. You can differentiate whether it's an inherited or acquired cause or a platelet or a coagulopathy problem. Then we learned three things: whether it is a vessel wall disorder or a platelet problem or a coagulation disorder, how to rule out from the presentation of the patient. If it's a vessel wall disorder, mostly mucosal bleed will be like a hereditary hemorrhagic telangiectasia. Then platelet problem, there will be petechia and also mucosal bleed, nasal bleed and all that. Coagulation disorder, mainly intramuscular and into the joint bleed, usually will have coagulation problems. Then we learned many things. One, dengue, we learned platelets less than 10,000, we need to transfuse, or with bleeding manifestations, irrespective of the count, we need to transfuse platelets. And also in minor procedures, if less than 30K, we need to transfuse. In major procedures, about 80K, that is what the textbooks say, we need to transfuse. Then we also learn about sequestration and hypersplenism. So to say as hypersplenism, there should be an enlarged spleen with reduction of more than 2 cell lines. And also it should be gone with splenectomy. I mean, it should become normal with splenectomy, right? That is hypersplenism. Then pancytopenia with hypersplenism is a tricky situation. So that also we'll have to properly think about that.
And about the categories, no? Reduced production of bone marrow, increased destruction of bone marrow, the gross category.
Yeah, the gross differentiation of thrombocytopenia. Yeah. We also learned about the major absolute contraindications for giving platelets in thrombocytopenia. One is TTP, then HIT, then DIC. That also we learned. Then situations where there is both thrombosis and bleeding is DIC, TTP, aortic aneurysm, splenic hemangioma, and all that. Then we learned about MPV, mean platelet volume, and if MPV is increased, meaning to say platelet is large, that means that bone marrow is producing more. So it confirms the peripheral destruction. That's a hyperproliferative bone marrow, and that will respond to steroids, and there is no use of transfusing platelets in that case. And also PLCR and PDW. PLCR normal means marrow production is less. If it is increased means marrow is producing more, I think. Then also 4T score, that we'll have to read up. Then different situations, we need to learn to analyze different situations. The differentials of diarrhea with decreased platelet, pregnancy with decreased platelet, then infections with decreased platelet. So we learned all that. Then what else? Also think
Pseudothrombocytopenia.
that
If
pseudothrombocytopenia.
if we are not able to
Also,
come to any conclusion, it will be pseudothrombocytopenia also.
always think of pseudothrombocytopenia. And also, all hematological disorders look for spleen, lymph node, very important. Also, send HIV, HBsAg, HCV, ANA profile to rule out secondary ATP. And also, two conditions we learned which will not have splenomegaly is ITP and aplastic anemia.
Okay.
Okay, is that enough?
Yes, done.
Okay.
Yeah, and the doubt.
Hmm.
This the major regulator of platelet production is the hormone thrombocytin, no?
Yes.
So is there any point in measuring thrombocytin?
In
We
it
can
is
give
measuring
that-
thrombopoietin.
Thrombocytin. And we measure
Thrombopoietin
thrombocytin.
therapy is available.
Yeah, that is what we gave that Dr. Ramurni. That is why I was going to
L-Thrombopac.
say that. Yeah, thrombocytin receptor agonist. Keto bro. നമ്മൾ രാമുണ്ണി
അല്ല ഞാൻ ചോദിക്കുന്നതാ ഈ thrombopoietin നമുക്ക് ലാബ് ടെസ്റ്റ് വെച്ച് മെഷർ ചെയ്യാൻ പറ്റുമോ?
അത്ര ഓവർ ആക്കണം. റിസർച്ച് ഇറക്കേണ്ടി വരും.
ഹൈ ലെവൽ
Dr. Firdause is thinking next level.
interleukin 6 no. Synthesis is increased with preservation and specifically by interleukin 6. നമ്മളിപ്പോ ഈ കോവിഡ് interleukin 6 and all. മെഷർ ചെയ്യുന്നുണ്ട്. We are measuring interleukin 6.
അതറിയാം. Okay, I think it is 40 into 3, 120 minutes almost.
Oh.
We have to cut short.
Yeah.
I thought
anyway,
no, it will be over within 30 minutes.
No, your presentation got over correctly in 30 minutes, but the discussion went on for a long time.
40 minutes. Okay, sir.
Okay, it was useful, right?
Nice one.
Yeah.
Of course.